This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thanks very much, Arthas. Again, it's a pleasure to be here. I kind of bookend this meeting. I was at the first session and the last, and I have to tell you, I'm very excited to see so many people still in the seats. I have a remarkable record of speaking in the last session of meetings, and I rarely see this many people here. So thank you to you guys for hanging in there. So my presentation is basically an argument that technology is required for the most effective reduction in RRT events. Now, having said that, I'm not sure we want to decrease it in the first place. Every high reliability organization has a recovery capability, so that if something happens that's untoward or looks like it might go bad, you have to have a system to catch that and then respond to it. And so it's easy to think about that in terms of a patient who's deteriorating, but it also tends to be a pretty good Geiger counter for things that can go wrong in the hospital. When we first started looking at this at the University of Pittsburgh, we found that 2 out of 3 RRT events were preventable through some kind of action. Giving the correct medicine instead of wrong medicine, getting a house officer there sooner, unrecognized. We found a number of medicine interactions that hadn't previously been described, and all by just analyzing all the events that occurred. We were up to over 3,600 events per year, and that is a rich database. And for the University of Pittsburgh, that was the single most important way we had to find things that go bad that matter. This is the difference between just trying to do things better. You can really focus on the ones that cause harm. So I'm not too sure that we want to decrease RRT calls. But having said that, this is our goal. For the hospital. We want there to be 0 preventable deaths in hospital. I think there's 2 prongs to this. One is to make sure all the people who ought to die, in the sense that Ken was bringing it up earlier, the people who realize that they're at the end of the life and don't want more invasive, more aggressive types of life-saving efforts. We have to find those people. And we also have to find the ones whose trajectory is to live and get them back on that trajectory if they're going badly. So this has been shown several times, and I want to make the case that we're kind of past this. There have been all sorts of studies showing that good outcomes with all kinds of responders. Including Michael Howell, who's now written a series of papers from a series of institutions, that you can, if you train and support the home team well, they can be their own rapid response team. It's just a matter of creating the criteria, teaching the people the time limits in which they need to respond, and then teaching them what the notifications have to be. Identical response rates. I think the real crux of the matter is, how do you catch the people? I think that is something that we're all struggling with, and I'm going to make the argument that you have to have technology if you're going to do this as effectively as possible. This is a study that Sanjay Galhotra and I and others did. We published this years ago, where we looked at the relationship between monitoring intensity and the diurnal variation that occurred amongst patients who went on to have cardiac arrest. Now, everybody knows there's a diurnal variation now in these events. We tracked it to the level of monitoring. And so if you look at the patients who were unmonitored, there was a 60% variability between day and night, with more occurring during the daytime, 12 hours. And if you were in the ICU, so you have increased staffing and increased technological continuous monitoring, there was no difference between night and day. And if you were lightly monitored, that means either an increase in nurse staffing, but below the level of ICU nurse staffing, or increased monitoring, usually, but not necessarily with continuous pulse oximetry, the frequency, the diurnal variation was somewhere in between. Both of these were significantly different from the ICU, and these were significantly different from each other as well. So basically, as variability decreases as monitoring increases, and that's important. That tells us that we're flattening out the expected random events that occur with patient deterioration. It should be evenly spaced around the clock. Now, another thing we found in the same study was what happens with the patients. And it was interesting to me that the sickest patients over here, which are the ICU patients, have the lowest mortality during the event. So if you have a cardiac arrest in the ICU, you have a 90% chance of surviving that event, 85. However, if you have a cardiac arrest on the floor, you have only a 35% chance of surviving the event. This is backwards. The healthier people should be more likely to survive. If you're lightly monitored, you're somewhere in between. And it's interesting that if you survive the event in the ICU, you're still likely to die during the hospitalization. If you survive the event on the floor, you actually have a little bit better chance, probability-wise, of surviving the hospitalization. But at the end of the day, there's no difference in mortality if you have a cardiac arrest, irrespective of where you are. And the only conclusion that I could draw from this slide is the only reason I would expect that the healthiest people are the least likely to survive is they were dead the longest before we started working on them. And we started some study. We called it the dead in bed study, and we started looking at it and found a significant number of patients who had normal vital signs. The next vital sign, the patient was already dead. Tried to resuscitate him, and this is what you see. An interesting thing that shows up here is the breakdown of the cardiac arrests. There were a roughly equal, there's no significant difference between the number of cardiac arrests that occur in the ICU and the unmonitored setting, slightly higher in those that were monitored. So the actual event rate, your risk of death, of having a cardiac arrest amongst unmonitored patients is 0.5 in 1,000. And your risk is 1 in 1,000 if you're in a monitored setting. The difference between this is extraordinarily low. You're talking about a 99% safety versus a 99.5% safety. People talk about triage and getting the people into the right level of support. There is no way you can discriminate between somebody who's 99% safe and somebody who's 99.5% safe. It can't happen. It's interesting to see this, and when I put this in context with some data that you heard, it's been reported elsewhere in this meeting, but Max Bell, maybe about 10 years ago, showed that 4.5% of patients in the Karolinska Institute at any one moment achieved MET criteria. Tracy Bucknell had almost identical data. She reported 3.5% to 5%. Meet MET criteria, and only 1 in 20 of those patients get a MET call. There's something funny going on here. If MET criteria are so important and we're making calls in only 1 in 20, how are we supposed to work this into our response system? There's something wrong with the criteria, and I think it has to do with the ability of the criteria to predict the future. And I mentioned this yesterday morning, so I'll say it very briefly. We are getting very good at figuring out the area under this receiver operating curve, but the problem is that the area over the curve is never going to be perfect. If we want to capture all the patients, we have to do something that's more than just looking at, in this case, Muse or news scores. We need to be continuously tracking patients because something can happen in between events. And I think there's some data to show that this is possible. I showed this yesterday. Also, this is Andreas Tanzer with his before and after and side-by-side comparison of continuous pulse oximetric monitoring in patients who are otherwise not destined to be monitored, and he showed a decrease in med events and ICU transfers just by having the nurses more notified earlier that patients were having some kind of deterioration. We looked at 100,000, more than 100,000 hours of continuous monitoring. First author was Marilyn Hravnik. This was in a patient where, in a unit that was a step-down unit for neurosurgical, neurotrauma, trauma, and intoxications, all on a trauma service. 75% of those patients who were deemed to be high-risk patients never had a single abnormal vital sign, not one. 70 during their entire hospitalization. 80% of the remainder had only one abnormal vital sign. The remainder, which is 5% of the total, they had either more repeated or a longer duration abnormality in their vital signs. And amongst those patients, only 1 in 5 had a Met call. So we were ignoring a lot of patients. So there's 2 points there. One is we don't triage well, and the second is even when we find events, we don't escalate it perhaps as well as we ought to. Interestingly, even though there were very few Met calls, in 3 years of continuous monitoring on that unit, there wasn't a single cardiac arrest. In 3 years on a neurotrauma unit, except for 2 patients who were not on the monitoring system. Those were the only 2 deaths in a 3-year time frame. And so I think there's something to be said for continuous monitoring. Certainly that's a form of technology. Now, having made the case, at least in part, for continuous monitoring, I'm going to show some side-by-side comparison of continuous and intermittent monitoring and the kinds of errors you could have. The first I'm going to call a sampling error. In sampling error, if the nurse monitors the patient here, she'll see the respiratory rate's 15. If she comes back a certain amount of time later, she might find that the respiratory rate is higher. If she comes back here, she'll find it in between. But in between these things, anything can happen, as it does right here. The respiratory rate went up, and then it went down to 0. And the next monitoring opportunity isn't going to be until off the slide here someplace. And you can see how the type of events I was talking about earlier can happen. People having essentially normal vital signs and then coming back later and finding them dead. So you would say, well, we have to do something better than intermittent monitoring. But if you do continuous monitoring, you can have the same sort of sampling error. This is a paper that was done by Andy Auerbach and one of his fellows, whose name I can't pronounce. But this comes out of San Francisco General. They are hospitalists there, and they were looking at the monitoring problem there. And they're talking about EKG monitoring, and they reported that 50% of the patients were being monitored on EKG just because the doctors were worried about some sort of deterioration. Well, the only kind of deterioration you can find with an EKG is tachycardia or bradycardia. And as you know, this is not the most common reason for making the call. It's hypotension and respiratory rate are more common reasons for calling than tachycardia. So 50% were for monitoring, and I think we're using the wrong modality, so that's going to be a sampling error. And 30% of the patients who were put on this monitoring system was so that they could attract more nursing care, hopefully. And I'm not sure this is the right reason to be doing monitoring. So the second is compliance error. This comes out of the MERIT trial, and I think this has been reported more than once during this session. And basically, we do not do a good job of collecting vital signs reliably on patients as they're supposed to. I suspect, I don't know this, and I would love somebody to study this, I suspect that Florence Nightingale in 1862 had a better record of compliance with getting all the vital signs she was supposed to than we do in 2010. So you would argue that intermittent monitoring, because it takes time, a particular skill set, may not be as good as possible, so we don't comply with what we're supposed to do. But the same thing happens with a continuous monitoring system. When we tried to put on we did a study in our cardiac step-down unit. to try to reduce our alarm time from 360 minutes per 180 minutes of real time. That's two alarms going off at the same time continuously for 3 hours. We started working on getting people to try first thing we looked to see how were people using their monitors. It turned out that patients were only actually wearing their monitors 40% of the time. Talk about a compliance error. It took us a month to get that rate up into the 80s, and it turned out that that was as good as we could do. Because it was an ambulatory unit, we had non-ambulatory pulse oximetry at that time that we did the study. And so we had to let people get out of bed to go to the bathroom and walk around the unit and go to tests and radiology. So I think the optimum compliance we could get on that unit at that time was only about 80%. So technology doesn't necessarily fix compliance. There's a recognition error, and I think this goes into that notion that only 1 in 20 people who have met criteria get a call. So people don't recognize those patients are in trouble, or they're accurately recognizing who's in trouble and who isn't, but our criteria aren't good enough. And I honestly, I don't know which way it is, but in any case, I have seen many patients where the nurses and the doctors at the bedside have a patient who is in florid septic shock and don't recognize it. And I know everybody in this room who responds to a med call has gone to a bedside, and I called because I had to call, but I really think everything's okay, and it turns out that the patient is a train wreck. So there is a recognition error. The way to fix this, and having a monitor doesn't necessarily fix this, but having a technological decision support system can. So if you have a system that can pick up the various vital signs and then say, this patient needs fluids, as some systems are now have available, or a perfusion index guide that can tell you we need to improve the cardiac output and there's variability, so we have to give fluid or we have to give inotrope. You can have a technologic support for the recognition error. That is often done on those between the flags charts. I don't know about in Australia, but in UK, the standard chart has at the bottom, if you have this many, you call this person. If you have that many, you call that person. And that is a non-technologic decision support that's useful. I'm going to go quickly through a couple of slides here. All technology goes from buildable, so we can do it, to we can do it in a way that you can move it from one room to another, to where you can wear it. Think EKGs. The first EKG was the size of a house. And now you don't have to have anything. You can just put a little patch on your chest and it will do a 12-lead EKG on you. This is a system that's a wristband wearable. This is only about 3 or 4 years old. There's now several similar items on the market. I saw one in Amsterdam at the Society of Rapid Response Systems meeting earlier this year, where this piece here was basically a stick-on that went onto the chest, and there were no probes at all. It's just a stick-on the chest. So this is moving fast, where we're getting to wearable. There's touchable technology. This is an accelerometer and pressurometer that goes underneath the bed mattress, and it can tell sleep cycle, turning, respiratory rate, and heart rate for a patient. There's been a large study by E.L. Zimlichman showing a decrease in RT rate and improvement in all-cause hospital mortality using a system like this. Now, one of the nice things about having all the data put into an electronic record is you can start fooling around with this. And so this would be technologic manipulation of data so it can help you make different kinds of decisions. And here you can see everything tracked for a particular patient. And you can see trending of data. And it doesn't actually matter what they're measuring, whether it's blood pressure or heart rate. But you can get a sense very easily. This can come up on your iPhone or your Android. You can get this straight to you from the patient's monitor without it having gone anyplace else. And having this support to know that, so this patient's blood pressure is now 95, I'm not too worried. It was 145. The blood pressure was 145 2 hours ago. You can pick up on trends. You can alarm trends as opposed to individual values. And this can be done real time and in your pocket if you want. A nice thing that you can do, if everybody in the hospital's data gets dumped to a system is you can start looking at severity of illness not for a patient, but for a floor or for a hospital. This kind of data on the unit nurse director's laptop, desktop, or in the director of nursing downstairs in the administrative offices can tell you whether your unit is staffed effectively enough or not. Right now, most nursing units staffed using some sort of severity score at the beginning of shift and at end of shift. Some will do a couple times a day during a shift. But you can do this real time. You can set this off. That alarm goes off. If your unit Muse score goes above a certain value, ding, and we can send nurses from over here where their severity score is low over to this unit where the severity score is high. And if you consider what a crisis is not just severity of illness, right? Somebody could have low blood pressure and high heart rate in the ICU. That's not a problem because you got all the stuff you need to fix it there. The same problem occurs on the floor. That's a big problem. And so in a nutshell, a crisis is a mismatch between the needs of the patient or the floor and the resources available. So if we have this kind of data, so that I can now bring extra nurses or doctors or respiratory therapists over to the unit, I can improve the safety for the whole unit because I am matching severity and staffing. I am resolving the crisis by matching resources and the needs. This is a very nice project done by Sangbum Hong at Asan University in Korea. This is a gigantic hospital. It has almost 3,000 beds. It's 2 huge towers. They have a supermarket and a couple of restaurants on the first floor. It is a marvel. So they have, they're technologically heavy, and they have everybody's data going into the computer system frequently, but not necessarily by continuous monitoring, and they get a screen that looks like this. And they sit down in this room here, there's Sangbum in the back, and they look at the monitors, and it's like so. And if they don't like somebody's trend or absolute values, they just go upstairs. Nobody calls the Met team. There's no calls because the Met team is on duty all the time. They find the patients that they want to look at, and then they go up. And they had a dramatic reduction in all-cause hospital mortality. And, of course, you can do that in the building. They do this on the first floor just around the corner from the supermarket. But you can also do this from far away. You have the same kind of decision support. People are trying to create systems of, within the hospital of collecting all the data and bringing it someplace so that the hospital has a continuous database. I think this is coming about very soon. I'm going to skip over that one. But I think we're about to undergo a sea change in the technology of a hospital that's going to be patient-centered. These are all devices that continuously monitor patients one way or another. And look at the price tags on these things. It's ridiculous. And I foresee patients coming into the hospital. Mom is sick. She's not being monitored. I'm going to go to the pharmacy. I'm going to buy one of these things. And I'm going to stick it on my mother because I'm worried about her. And I think that the real driver in the improvement in monitoring in hospitals is going to be patient demands. These devices, particularly one like this, which is the iWatch, that can hold an entire patient's medical record for their entire life on their wrist. Imagine what that can do for your healthcare as you move from organization to organization. So where we stand now, FedEx knows more about its packages than we do about our patients. This is a travesty. People at home who are sick are watched like hawks by the ones that love them. You bring them into the hospital, we watch them every 4 hours, maybe. And so the monitoring goes down when you come into the hospital. But there's technology to fix this, and I think we're going to see a huge change in the next 5 years. Thank you very much.